Hi, my name is Kimberly Escalante, and I'd like to thank the Congressional Committee for the time that you are investing listening to this presentation. I want to draw your attention to the topic of rehospitalization and why it's important in our nation. But first, let's define what rehospitalization is. Rehospitalization is the unplanned readmission to an acute care hospital within 30 days after discharge from a hospitalization. Patients can be readmitted for any reason. For example, a patient can have an unplanned visit to the hospital after an outpatient procedure. This is the national scorecard on the U.S. health system performance in 2011. The data here shows no drastic improvement in decreasing hospital readmissions. So what this ultimately means for us is that we have room for improvement. I just want to briefly bring you to the Medicare website. It contains a full list of readmission reasons. Let's take a look at one example. Excuse me. And when you click on the full list of readmission measures, it brings you to another website, and as you can see in the first row, it shows reasons patients return to the hospital. The first row is in regards to hospital visits after an outpatient colonoscopy. It is collected annually. The last time it was updated was December 31st, 2018. I would highly suggest going down the list to familiarize yourself with the reasons patients revisit the hospital. Hospital Readmission Reduction Program. So Medicare created a policy called the Hospital Readmission Reduction Program. It is a program that is designed to encourage hospitals to improve communication and care coordination to better engage patients and caregivers in discharge plans and in turn reduce avoidable readmissions. The program supports the national goal of improving healthcare for Americans by linking payment to the quality of hospital care. It reduces payments to inpatient prospective payment system hospitals for excess readmissions beginning October 1st, 2012. The Centers for Medicare and Medicaid Services includes the following 6 conditions and or procedures. And as you can see, I have listed them there, so you don't have to go and look for them. So how does Medicare measure and obtain this information? Patients that are included are Medicare beneficiaries 65 years or older who are enrolled in Medicare for 12 months before their hospital admission. The readmission measures do not include patients who died during the index admission or who left the hospital against medical advice. The information comes from Medicare claims data and eligibility data. Using claims and eligibility data makes it possible to calculate readmission and death rates without having to review medical charts or requiring hospitals to report additional information. Medicare conducted research during the development of the initial readmission and death measures, which showed that measures that use claims data performed well compared to measures that used information from medical charts when estimating hospital readmissions and death rates. Risk adjustment. To accurately compare hospital performance, the readmission and death measures adjust for patient characteristics that may make readmission or death more likely. These characteristics include the patient's age, past medical history and or diseases or conditions or comorbidities the patient had when they were admitted that are known to increase the patient's chance of dying or of having a readmission. Centers for Medicare and Medicaid Services calculates the payment reduction and component results for each hospital based on its performance during a rolling 3-year performance period. The payment adjustment factor is the form of the payment reduction CMS uses to reduce hospital payments. Payment reductions are applied to all Medicare fee-for-service base operating diagnosis-related group payments during October 1st to September 30th. The payment reduction is capped at 3%. Then CMS sends confidential hospital-specific reports to hospitals annually. CMS gives hospitals 30 days to review these reports and submit questions about the calculations of their results and request calculation corrections. So what can we do? We can create or allocate funding to community programs that bridge the gap for patients turning to hospitals, then to community healthcare centers as a first line of defense. We can invest in research to create tools to implement in the hospital to flag patients who are at high risk for readmission. For example, according to a study conducted by BEIG in 2019, the two most common risks for readmission assessments are LACE, Readmission Index, and PAR. LACE stands for Length of Stay Days, Acute Emergent Admission, Charlson Comorbidity Index, Number of Emergency Department Visits within 6 months. PAR includes gender, age, race, cost, weight of last admission, code for last submission, diagnosis for last admission, and number of acute admissions in previous 90, 180 days, and 2 years intervals. Using this information and collecting more data if needed, we can create a policy to deter patients from turning to hospitals as a first destination and finding a solution to incentivize community centers so that patients can turn towards primary health care providers rather than hospitals for their care. If you want some more information, please visit these websites. Thank you. Again, I'd like to thank the committee for its time. I do understand it's a very long presentation and there's a lot of information that is entailed to it. So again, thank you.